welcome to the most exciting session of the day, myeloma. So it's actually my great pleasure to introduce one of our colleagues and one of the myeloma experts in current era, Dr. Al-Ola Abdallah. He's an associate professor at Kansas University, and he specializes in myeloma and leads the myeloma program at the Kansas University Medical Institute. He will be talking today about, in the first talk, CAR-T versus SPITE in the management of myeloma. Dr. Al-Ola, the floor is yours.
Thank you very much. Thank you very much, everybody, and thank you for inviting me to talk today about a very important subject, which is CAR-T versus SPITE in multiple myeloma. I'm going to talk a little bit about, first of all, I don't have any financial relationship to disclose. So we're going to talk really about the FDA approval treatments, and we're really excited about that because we have 2 BCMA CAR-T cell approved, the ide-cel, cilta-cel, 3 BCMA bispecific, teclistamab, erlotinib, and linvolistamab, and we also have talquetamab, which is a GPRC5D bispecific, which is very important to us as well to talk about it today. Now, before we talk about the BCMA-directed therapy and the CAR-T and the bispecific, we have to understand why we actually needed that. We all have really great options of therapy, including the immune modulatory drugs, proteasome inhibitors, and also the monoclonal CD38. As you can see, this is one of the studies that was actually kind of published to tell us about the patients who are, refractory to either triple class refractory to 3 classes versus also penta refractory to 5 drugs of the 3 classes. And you can see the survival was not very good in these patients, about 9 months for triple refractory, and for penta refractory was about 5.6 months. Historically, the best drugs that rarely give us 20 to 30% response rate, so we didn't really have any great options of therapy. So why did we really need a BCMA-directed therapy? So before we go for any of the clinical trials that we have actually did some of the studies internally in KU, and one of the things is that we looked at patients who have actually been to refractory. We found out the overall survival for these patients was actually 12 months, which is kind of surprising. But when we actually reanalyzed the data, patients who got BCMA-directed therapy, whether it's CAR-T or bispecific, the survival was about 17 months versus those who didn't get it was 6 months. So there was a survival benefit that we believe that was actually shown in patients with penta refractory myeloma. Now, moving on to the advances of CAR-T cell in myeloma, of course, we know exactly the process of leukapheresis, transduction of the BCMA, and I want you to remember BCMA is a very important antigen in myeloma. It's present in 95% of the myeloma cells. And you can see exactly that, the expansion of the CAR-T cell, and then after that, the infusion. So it's the time, vein to vein. It can be between 1 to 2 months in myeloma patients. So the first clinical trial we want to talk about that led to approval of the first BCMA CAR-T cell was the KarMMa-1 study. As you can see, these patients were most of them triple exposed. Many of them were triple refractory myeloma, so we didn't have any great options after that. These patients received ide-cel, and it's the same conditioning regimen that we use in lymphoma, fludarabine, and Cytoxan, and then after that, CAR-T was infused for these patients. The response rate was evaluated, as well as the progression-free survival, overall survival for these patients. However, you can see that we were very excited about the response rate. Is historically was 30%, and you're talking about 73% for the total population. But if you look deeper, those patients who got the higher dose, 450, was 81% the response rate. All the patients, of course, when they evaluated the subgroup, whether they're high-risk myeloma, they were extramedullary disease myeloma, they have penta refractory or triple refractory, they benefit from the ide-cel treatment. So the ide-cel treatment as a BCMA CAR-T was showing really very great efficacy. Now the progression-free survival was not very impressive, because for the total population, it was only 8.8 months, unfortunately. And the patients who got 450, I think these patients have a 12 months. The patients who got a higher response rate, complete remission, you can see that they have a duration of response over 20 plus months. So they were doing much better in that case. The overall survival for the patients, as we talk about historically, was less than 1 year, but you can see here is that it was about 22 to 25 months, so it was 2 years. So patients who got CAR-T cell really actually benefit from this treatment. Now, to move to a different product, cilta-cel was there as well from CARTITUDE-1 study. And it kind of was the same as the KarMMa-1 study, except that, they have 113 patients. They only infused for 97 patients. And what they actually look at is also the same thing. The response rate was really impressive, about 97%. You can't actually compete with that. The median progression-free survival was over 34 months, and at the time, the median overall survival was not reached. And due to these results, the FDA approved this treatment. Now, in the myeloma world, that's not enough. For myeloma doctors, they want you to compare these treatments to standard of care. And this is what happened in the KarMMa-3 trial. You can see that this KarMMa-3 trial, they actually took the ide-cel and they compared it to the standard of care. And as you can see here, we have 5 different options of therapy, because in myeloma, we have many options for relapsed myeloma. That was one of the issues. But they made a good thing here, is that if the patient progressed in the standard of care, they were allowed to cross over and receive CAR T-cell afterwards. So you can see here is that the response rate for the CAR T-cell, the ide-cel, was 71% versus 42% in the standard of care. The progression-free survival was about 14 months versus 4 months. But however, the overall survival, there was no any differences. And the reason they explained that, patients who got the standard of care were allowed to get CAR T-cells. So that's why the survival benefit was not there. Now, to move to the right direction with the cilta-cel, cilta-cel made the same study, but they made 2 different main changes. First of all, they restricted the standard of care only to 2 regimens, Dara-Pom-Dex and Velcade-Dex. Number 2, they did not allow patients who got the standard of care to receive cilta-cel. So they did what the ide-cel did. So what we saw here is that the response rate was better, 84% versus 67%. And as you can see, the median progression-free survival was not reached in the cilta-cel versus it was 11 months in the standard of care. Longer follow-up actually showed there was an overall survival benefit, but the explanation here is that these patients did not receive a BCMA CAR T-cell. That's why the cilta-cel group did much better. Also, the MRD negativity actually kind of was a predictive for the PFS and overall survival for these patients. It was better in the cilta-cel arm. So that led us to actually move the cilta-cel to a second line of therapy based on the new FDA approval. Now, not everybody or every patient, unfortunately, for myeloma will receive a CAR T-cell. But we have to understand that's the problem that we struggle about. So we need another option, especially BCMA-directed therapy was very impressive for the results. So we have the bispecific, and the bispecific is like lymphoma, but our target, we really focus on 2 different targets. We have 3 bispecifics that target BCMA, the teclistamab, the elranatamab, and the linvoseltamab, while the talquetamab, target the GPRC5D. Now, we're going to talk about the efficacy before we move on to the side effects. So the efficacy, I kind of put all of the 3 trials, the Majestic, the Magnetic, and Linkers trials, and you can see that these trials focus on triple exposed and triple refractory myeloma with great performance status. And the whole purpose of putting these slides together is not to compare the efficacy, it's to show all the efficacy together for these patients. So when you can see the patients who got teclistamab, and elranatamab, and linvoseltamab, you can see the response rate varies between 60 to 70%. So it's an effective single-agent treatment. While if you see the median progression-free survival, you can see it was about 11 months in the teclistamab arm. Elranatamab arm was about 17 months. The 18 months progression-free survival in the linvoseltamab arm was about 60%. Now, the commonest question I receive from a lot of colleagues is that, which one would you choose? I would not use this slide. The actual slide I will use is this one, is that which one is more convenient for the patients. The step-up dose actually is the one that makes a difference, and eventually the frequency of the treatment. I mean, if I have a treatment that I will decrease the frequency instead of doing it weekly every time indefinitely versus moving to every other week or once a month or maybe stopping the treatment, I think that's the best option of therapy that I would prefer. So to shift the gear, we talk about, all the BCMA-directed therapy. We definitely need it, unfortunately, because of myeloma is an incurable disease. We need another, target, and GPRC5D, which is a very important target therapy we found using the talquetamab. Now, this is a study that actually compared the dosages, which 0.4 milligram was given after step-up dose weekly versus 0.8 every other week after the step-up dose. And as you can see here, is the difference is that the response, not the response rate, the progression-free survival was 11 months in the 0.8 milligram versus 7.5 months in the 0.4 weekly. And the median duration of response was 17 months in the 0.8 every 2 weeks versus 9.5 months. So it makes a lot of sense to use the 0.8 milligram every other week, which is more convenient for patients after the step-up dose. So that's exactly what we started using it for this. Now, we talk about the efficacy. So we understand here CAR-T BCMA and bispecific BCMA and the GPRC5D bispecific, or talquetamab, all of them are effective treatments, so no doubt about that. But we face a bigger problem. One of the biggest problems we face is the adverse events. And of course, we all know these adverse events and the problem about, restriction to use it, especially in university hospitals don't have that problem, but, you have community oncologists that are worried about using these drugs, especially the bispecific, due to CRS, ICANS, any movement disorders, infections, or cytopenias, or now we have a new section, GPRC5D toxicities. So I'm going to talk a little bit about the CRS and why is it important, because we want to try as much as possible to do most of our patient CAR-T cells and bispecific outpatient. So we all know about the ide-cel, cilta-cel have higher grades of having CRS, while the bispecific teclistamab, elranatamab, linvoseltamab, and talquetamab have a lower rate. Even the grade 3 was lower. And I think you can see exactly, cilta-cel is the commonest that we use in our institution. So we have a prediction that these patients will have a median onset of 7 days. So we started to actually do the cilta-cel infusion outpatient and wait for the 7th day and kind of like follow these patients very closely if they need to be admitted to the hospital. Now, in the bispecific, we're much better now and we're more confident that we can do it outpatient, because now even in step-up dose, we know exactly what percentage of patients are going to get CRS, in the step-up first and second and the third dose. And that really is helpful for us, because also that will give us more prediction about how we can follow up the patient closely and readmit them if needed to be for CRS. Now, the management of the CRS, it's more supportive care. And the question about tocilizumab, every institution is different, but our institution have a low threshold to admit the patient, do an infection workup, and give tocilizumab for these patients. And I think we're doing a little bit much better because we don't have any major complication or grade 3 or 4 of CRS, whether they're CAR-T or bispecific, especially after we move these patients outpatient. But now we're a little bit getting greedy, is that we don't want to see a CRS at all. So we're now talking about giving patients prophylactic tocilizumab. And everybody have heard this news, that can we actually give these patients, if we feel that they're high risk, can we give them tocilizumab in order to prevent the CRS in these patients? And although there's not really good prospective studies, but some of the studies, even the Majestic study that shows that there was actually a decrease in the CRS from 72 to about 25%. Some of the retrospective studies was talking about a 10%, especially in the bispecific. So I think it is actually reasonable to have that discussed, about especially if the patient is a high risk for CRS. The ICANS is another side effect that actually we have a lot of problems and struggle, but you can see that the cilta-cel, ide-cel is commonly having this, comparing to the teclistamab and the other bispecifics, especially grade 1 and 2. And as much as it actually causes a lot of side effects, if the patient is high risk, we usually refer them to neurologists. Sometimes we start them on prophylactic anti-seizure medications. We try to avoid, especially in CAR-T cell, dexamethasone, unless, they start to develop these symptoms. But, in the bispecific, most of the time we stop the drug, and we see that their symptoms is reversed, especially they have earlier grades. Now, we're facing a bigger problem is the delayed neurotoxicity, especially in the cilta-cel, is that those patients who get cranial nerve palsy and Parkinsonism. We have a few cases, and I think these are cases that kind of concern some patients. And to be honest with you, some of the patients have actually requested to delay their CAR-T cell treatment due to the concern that they don't want to have any kind of persistent neurological side effects from that. And I think that's also one of the issues. Cytopenia is considered as a common side effect, especially in CAR-T cell. And sometimes, we actually have to not, although we use supportive care treatment like growth factor shot, sometimes we have to use drugs like Promacta and, Ipogene to help out these patients. But I think, if the patient have persistent cytopenia, the major treatment that helped is stem cell boost. So we have been using stem cell boost in these patients. The bispecific, on the other hand, is very easy to treat these patients. Most of the time we stop the drug, and give them growth factor shot, and that really helps a lot of these patients. So we have seen like less severity in the cytopenia comparing to the bispecifics versus the CAR T cell. Now, the GPRC5D have really huge toxicity, field, and we have seen that a lot. It's a very effective treatment. Believe me, it's one of the greatest drugs. But unfortunately, it have really bad side effects. Like, I tell you that patients have stopped it due to the side effects. Dysgeusia and dysphagia and dry mouth, these are side effects that lead to loss of weight. And we're trying as much as possible to find very supportive care treatments. Rash, and skin peeling, is common that we see these patients, but it's really treatable. And also some nail disfigurations that we see in these patients. And as much as they tell you that even after you stop the drug, I can see that the side effects can last for months, not only weeks, for these patients. However, most of the studies kind of concluded that reducing the dose, which I kind of like do it and I prefer it, actually plays a big role in these patients. As we can see that the side effects of toxicity of the oral toxicity, skin toxicity, and the nail toxicity drop down after you reduce the dose and decrease the frequency. So usually these patients, unfortunately, they receive the talquetamab as a last option of therapy. And as you can see that you don't have any other options left, So what I prefer is to hold the drug, especially if they're responding, and try to kind of decrease the dose and the frequency in order to have a tolerable treatment. And the last thing is I want to talk about the infection. I think the cilta-cel ide-cel, you can see on the right side, it has less risk of infection comparing to the bispecific. So this is the only treatment that you can actually see if the bispecific have more toxicity than the CAR T cell. And there's a reason for that, which is that the B cells are getting depleted and patients have low immunoglobulin levels and higher risk of infection. The mortality rate, if you actually look at it, from combination therapy of two of the drugs, teclistamab, talquetamab, was about 15% in the redirect treatment. And that's one of the things that was a red flag, to actually start the patients on a combination therapy due to the infection rate. And I think that's why we start these patients on aggressive supportive care treatment, whether if they're neutropenic, try to give them growth factor shot. If they have low immunoglobulin levels, we try to give them IVIG to keep the immunoglobulins above 400, and sometimes even if they didn't have any primary infections. And so we're aggressive in terms of like treating them, from any kind of infections for these patients. So we always have to kind of like mention it. Comparing to the CAR T cell, I think we see the infection rate, but I will say that it's not as common as what we see in the bispecific. And this is one of the reasons why we like to kind of like decrease the frequency of treatment of bispecific in these myeloma patients. Now this is kind of like just a summary for CAR T and bispecific, and kind of like talking about why do we choose CAR T versus bispecific. And I think I get this common question, which I don't understand why we asking the same question all the time. CAR T versus bispecific, which one you prefer? I don't think that's the right question. In myeloma, you need both of these treatments. It's still an incurable disease. If you give CAR T, patients still going to progress. Even if you get a durable response in some of the patients, you'll still need a bispecific. So I think the right question is that, how do you sequence the treatment? I think that's the best question I ask in myeloma and relapsed myeloma. And here's my best answer. In CAR T cell, I prefer it over bispecific for a major reason. It's more advanced in clinical trials. You have phase 3 trial that proved that CAR T cell is better than standard of care. The bispecific, we still have ongoing trials yet. We don't have any proof that bispecific is better than any of the standard of care. I know there's many studies to actually show combination therapy is better, but we have to be very careful to choose a bispecific over CAR T cell based on efficacy or safety. Number two, it's actually logistic reason, or more convenient. So the reason I use the CAR T cell is that if I can give you a one-time treatment, you don't have to come every week or every 2 weeks to get other treatments, and I'm not going to exhaust your T cells. And if I can keep you in remission for 2 years, and after 2 years I can use a bispecific, I think your immune system will be back to its normal, that I can reuse a bispecific. But if I give you a bispecific every week, I'm exhausting your T cells, I think the chances, even the question mark about how good we are to manufacture the CAR T cells, and how good or effective the CAR T cell in actually treating the myeloma. So I really actually prefer to use CAR T-cell over bispecific. Of course, there's a lot of things like eligibility, if the patient is eligible or not, that we have to look at it in that case. I think that was my last slide, and thank you very much.